So just as an introduction, cardiovascular disease is the leading cause of death in women. It accounts for up to 35% of all deaths worldwide in women. Despite this alarming rate, cardiovascular disease is still understudied, underrecognized, and undertreated. Clinical trials also underrepresent women throughout the cardiovascular disease spectrum. And heart failure actually can be divided, as many of you know, into heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. About half of all patients with heart failure have heart failure with preserved ejection fraction, or HFpEF. And in the US, women outnumber men for incident HFpEF by 2 to 1. The diagnosis is a little more subtle than with HFrEF. It's not as straightforward when identifying it, with nuanced echo parameters and having to assess filling pressures. And for this reason and others that we'll get to in the upcoming presentations, up to 64% of patients with HFpEF are undiagnosed. There's a lot of risk factors for heart failure that are the same in men and women. There are traditional risk factors like obesity, diabetes, hypertension, but there is also sex-specific risk factors that can affect women more so than men and can lead to this higher incidence of HFpEF. It's not just one single thing that makes disparities in the care a reality. All patient, physician, and systemic factors all contribute to delays in diagnosis and care. Women have different presentations of symptoms compared to men, and that can delay diagnosis. They're less likely to receive guideline-directed medical therapy compared to men. And oftentimes they receive routine care from clinicians who may not be specialized in cardiovascular disease. For example, if OB-GYNs are being used as PCPs, et cetera, they may not necessarily focus on the cardiovascular disease risk factors. So those risk factor assessments may not incorporate these factors, and therefore cardiovascular risk can be underestimated by both patients and physicians. In clinical trials, they're also very underrepresented. Though they represent half of heart failure patients, they are only in about 20 to 30% of heart failure clinical trial participants over the past several decades. And that makes it difficult to generalize the guidelines that we have for HFpEF just to the care of women. And the care of women is important. When patients have HFpEF, they report lower quality of life, more physical limitations, and more anxiety and depression compared to men. Though they have a lower 5-year mortality compared to men, they are more likely to be readmitted with heart failure within 5 years, have longer hospitalizations, oftentimes are discharged to places other than their home after discharge, and have an increased years of life lost. So if we can recognize the signs and diagnose heart failure earlier in women using clinical history, physical exam, and nuanced imaging techniques, we can work towards early detection and early action instead of late reaction. So with this, we can hope to improve quality of life, reduce hospitalizations, and improve long-term outcomes, especially in our HFpEF population.